Thank you so much for joining us for the fifth installment of the Evolution of Mindfulness speaker series, where today we will explore an especially timely and important topic. We'll be looking at mindfulness or medication, what the research says about treating anxiety. So my name is Frances Sadi, and I am the Associate Director of Non-Degree Programs here at Brown University's School of Professional Studies. Here at Brown, we are proud to offer a growing portfolio of evidence-based mindfulness programs, including short courses, teacher training certificates, as well as free public events like today's talk. At the School of Professional Studies, our mission is to develop innovative and rigorous, flexible educational programs that empower dynamic professionals to lead positive change in their fields, in their communities, and in the world. Our mindfulness offerings, developed in close partnership with the Mindfulness Center at Brown School of Public Health, are a reflection of that mission. They bring together scientific research, contemplative wisdom, and real-world application to support well-being, resilience, and human flourishing. This year's Mindfulness Speaker Series was created to spotlight the evolution of the mindfulness field by honoring the pioneers who laid the foundation and elevating the researchers, clinicians, and educators who are shaping the future. Over the past few months, we've had the honor of hearing from leaders like Jon Kabat-Zinn, Richie Davidson, and Zindel Segal, each offering insights into how mindfulness has grown into a dynamic, interdisciplinary field, bridging science, health, and everyday human experience. Today, we turn our attention to clinical mental health and specifically to the treatment of anxiety, which is one of the most common mental health challenges worldwide. We are truly honored to be joined by Dr. Elizabeth Hoge, a professor of psychiatry at Georgetown University Medical Center and director of the Anxiety Disorders Research Program. And for those who are unfamiliar, one of the studies we'll be discussing today is called the TAME study, short for Treatment of Anxiety, Mindfulness versus escitalopram. Sorry. This was a randomized clinical trial led by Dr. Hoge and her colleagues at Georgetown University and conducted between the years of 2018 to 2020 across 3 major medical centers in the United States. It is the first study of its kind to directly compare mindfulness-based stress reduction, or MBSR, to Lexapro, a leading SSRI for the treatment of anxiety disorders. So the trial enrolled 276 adults with diagnosed anxiety conditions and found that MBSR was as effective as Lexapro in reducing anxiety while producing significantly fewer side effects. And Dr. Hoge will get into it, talking about the study more. So the findings of this study were first published in JAMA Psychiatry in 2022 and have helped shape the national conversation around evidence-based, non-medication approaches to mental health treatment. Her work not only challenges assumptions about what effective treatment can look like, but also offers grounded, data-driven insight into how mindfulness impacts the nervous system, emotion regulation, and even brain activity. So we're excited to learn more about this growing body of research and what it may mean for clinicians, educators, and anyone navigating anxiety in their own lives. Facilitating today's conversation is Dr. Eric Laux, the director of the Mindfulness Center at Brown. Many of you know Eric as a thought leader and research pioneer. His work on mindfulness, stress physiology, and public health continues to shape the field globally. So before we begin, just a few housekeeping notes. So today's webinar is being recorded, and we will, as we have in the past, send out a follow-up email with a link to the recording sometime probably early next week. And throughout today's conversation, we do invite you to engage deeply. So please use the Q&A feature found at the bottom of the Zoom screen to submit your questions. And we will also be drawing both from the thoughtful questions that many of you have submitted in advance, as well as pulling from some questions that come in live during this session. Lastly, just a quick note. So after today's event, we're actually going to be pausing this series for the summer months, and we will pick things up back in September with more great sessions to come. And with that, it's my great pleasure to turn things over to Dr. Liz Hoge and Dr. Eric Laux. Thank you both for being with us, and thank you to everyone online. I hope you enjoy the session.
Thank you, Fran, and Thank you, Liz, for joining us today. I think we've known each other for maybe close to 15 years or so now. When I was, just getting into the mindfulness research side of things, I had a strong personal mindfulness practice, but you and others in the Mindfulness Research Collaborative were just instrumental in really helping me develop as a mindfulness researcher. And I've been always grateful for that. And I think for me, when I look at your career and some of the contributions, some of the things that stand out for me are one is that you're not afraid to ask big questions. And secondly, that you answer them with strong methods, whether it's putting people through, standardized stressors with a tree or social stress task, having their arms catheterized and pulling out blood samples every several minutes to measure various different stress biomarkers to uh, doing federally funded, clinically meaningful interventions comparing, say, MBSR to Lexapro, for example, along with assessing telomere length and all kinds of different things. So really appreciate the contributions that you've made to the field and also the generosity of your time, both as a researcher and as a psychiatrist and a clinician, spending some time with us today and with our audience. So really thank you for being here. Really, really appreciate that.
Of course, I'm happy to do it. Thanks for your kind introduction. And yes, I remember those early days in our New England Meditation or Mindfulness Consortium. Those are important, formative times for all of us.
Yeah, thanks. So with this seminar series, we're starting off asking a similar question to all of our speakers. And so would be curious if you'd like to share just what first led you to be interested in mindfulness.
Yeah, well, in high school, I was interested in meditation, and I grew up in DC. So when I was driving on 16th Street one day, I saw the Buddhist Vihara, and I was like, what is that? What is that? What are they doing there? So I went to some classes there, but then I forgot about it for years. And then it just so happens that when I was in medical school, I was moving out of one apartment to another, and the previous person in the new apartment had quickly thrown a lot of stuff away because they were trying to, quickly move. And in the pile was Jack Cornfield's book, A Path with Heart. And I was like, oh, that's cool. Let me take this and, check it out. And so reading that book was really transformative. And I thought, wow, this is really something powerful that I want to learn more about. And so I ended up going on a meditation retreat with the Spirit Rock folks. Ended up doing my internship at Stanford, so I was in California, and Jack Cornfield was there at that retreat, and I remember, because we have 15 minutes to talk with meditation teachers, thinking like, can I ask him to sign my book? Would it be nice? Would he be, willing to, or should I reveal to him that I found it in the trash, or is that okay? Like, or maybe he wouldn't care about that. you know, doesn't have that kind of ego, like some people. So I thought, why not? So I brought it to him and explained my story, and he said, "That's wonderful," and he signed my book. So that was great, and the retreat was great, and that started a practice of mindfulness.
Hmm.
And then I'll just also say on the research side, this is where they come together. I was trained as a clinical trialist, so for my professional career, I was always interested in, determining how we can figure out which treatments for psychiatric disorders are the best. How do we uh, really measure accurately and precisely what aspects of different kinds of treatment approaches would be helpful for treating anxiety. And I ended up during residency in the anxiety research group. And so that's what formed all the research initially. So I was doing drug trials originally, looking at new and emerging drugs, and also drugs that were brought back from other drug classes to see if there's a way that they could be used adjunctively or in some other way for the treatment of anxiety. So that's the basis of this approach.
Thanks. So cool to hear how you learned about mindfulness and the sort of circuitous routes that you found out about some of the teachings of Jack too. So thanks for sharing that. So yeah, why don't we shift into sharing a little bit more about your research? I know you prepared some slides and a bit of a talk on that to give folks an overview. So be welcome to shift into that phase if you like.
Okay, great. So first I want to just talk a little bit about what the basis of the study design is, because I think that's one of the most important aspects to point out the context. Here's the study that Fran mentioned, the treatments for anxiety, MBSR, and escitalopram, which is the same as Lexapro. This is just the generic name, escitalopram. And the idea was we received feedback from the AHRQ and other groups saying that for when meditation research got going, they said, you know, we don't really understand how meditation compares to treatments I already knew about. Like a lot of people were doing like, okay, what about meditation versus nothing? You know, in that case, you can see a signal in terms of treatment effect for meditation, but they said, well, you should really be measuring them against standard therapies. Otherwise, we have no idea how to understand the place for meditation as a treatment in a clinical setting. You know, how does it compare with something we already do, like psychotherapy and medication? So that was the idea behind this study design. So you can see the patients with anxiety disorders are randomized to these two treatments, half and half, so a one-to-one randomization. Either they did the standard MBSR, which as most people here probably know, is an 8-week program with classes once a week for 2.5 hours and 45 minutes of meditation at home, other practices. And the drug escitalopram is widely used. It's one of the top medications. It's generic, so it's inexpensive, and it works for anxiety disorders. So we thought it would, even though these are really different treatments, it would make the most sense to compare MBSR against something that we already know a lot about. Now, you might be thinking, how are you going to get people who are willing to be randomized to one of these two treatments, right? These are so different. And the kinds of patients who come into clinic wanting a medication are totally different than the kinds of patients who want to learn meditation. I mean, sometimes there are overlap, but that's often the case. So it took a little bit of convincing to get people to agree to be randomized to one of these two very different treatments. And one of the ways we did that is at our site at Georgetown, we said, you know, if you get into, you're randomized to the treatment that you don't want, just hang on. And after the study is over, we can give you free access to the opposite treatment so that they can feel like they can get something out of it that they want. So in this case, the design is to look at, instead of like a horse race, like this one's better than the other, which is a lot of times the design of clinical trials. In this case, we wanted to hypothesize that both will increase anxiety symptoms. And the way we say that in the study design language is non-inferior, which is kind of a crazy term, like non-inferior. That doesn't sound very impressive. Like, oh, great, it's not inferior. But non-inferiority is a powerful tool to measure how a new treatment might compare to an old one. And the FDA accepts non-inferiority trials for phase 3 registry trials for a drug. So it's a perfectly legitimate study design. Oh, this is the little joke about non-inferior, great. But it is meaningful and it is statistically rigorous design. And this is what, just to show you what it would look like in a study where you're comparing two treatments, you establish a non-inferiority margin ahead of time so that scientists can show that they're not playing around with the numbers because the margin is already established before the study is even started. And then you look to see if the difference is within this non-inferiority zone. So here's our study again, this treatments for anxiety, MBSR, and escitalopram. And in this diagram, the patients flow through the study from left to right. So here you can see the list of different kinds of anxiety disorders in case anyone was curious. it's not only generalized anxiety disorder, but also panic disorder, agoraphobia, social anxiety disorder. And the reason we did it that way is that there's a lot of comorbidity in these disorders. So it doesn't make sense to try to carve out like just GAD or generalized anxiety disorder, because half those people will also have social anxiety disorder. They tend to overlap a lot in a clinical setting. So patients were screened by a clinician. Then they did a lot of surveys, which is at the baseline visit here. And then over the 8 weeks, we asked them to fill out additional surveys. And they also had interviews with clinicians so that they could have like a more objective assessment of their disease severity. And you can see the main outcome, it was the Clinical Global Assessment of Severity, is an established research study type of measurement where blinded clinical assessors would interview the patient and then assign them a level of severity. So I know that some of you are thinking, well, don't you want to blind participants or mask participants to the treatment that they're getting, like you would in a drug placebo study, right? They don't know what they're getting, so they can't unconsciously affect the results. Well, you can't do that here, right? Because you can't, people know they're doing meditation or taking a drug. There's just no way to do blinding. So instead, we blinded the clinical assessors. So they would walk into the room, there'd be a participant in the trial who they would interview, and then they'd assign a rating, not knowing which group they're in. And here's the results. You can see that the confidence interval crosses 0, suggesting that the groups are not significantly different, and the lower end of the confidence interval falls within the pre-specified non-inferiority margin, this gray shaded area, showing that MBSR is a little bit less, but not inferior to the escitalopram. And we did this for both the top one here is the per protocol sample, and then this is intent to treat sample. So to be the most rigorous, methodologically rigorous, we have analyzed both samples, and we can talk about that more if people want. Here's another way of showing the data where we use an intent to treat analysis using longitudinal data, combining all time points, and use linear mixed models. But you can see here that the numbers are very similar to each other and overlap on almost all time points. Okay, so that's all for my first set of slides. If we want to, or we can talk about adverse events, or if anyone has questions about anything so far.
Yeah. Well, one of the questions that came in was, can you walk us through how mindfulness actually helps with anxiety? Like what's going on in the body, the brain, when someone practices mindfulness that might explain why it helps them feel less anxious? And so it's like really interesting data, but like, how do you think it's operating?
Yeah, it's a great question. And of course, we don't really know, but we talk to patients who go through the trial and try to get a sense of what their experience. And from what I heard from study participants, it seems like the practice of mindfulness helps distance from some of the stimuli that come up during meditation. So they're taught, to just be aware, of any thoughts, feelings, emotions, memories that arise during a meditation session, but not to engage with it and just to let it pass away. And that action of practicing letting it pass was powerful and led them to be able to experience worries the same way. So a worry comes up, and in the past they might be like, oh gosh, I got to think about that. What if this happens, and how am I going to handle it? They would see it as an external thought and say, oh yeah, broken record. Yeah, I'm not going to engage with that right now. And it gives them a little bit of distance and a little bit more choice about whether or not to be engaged with those kinds of worries or other anxiety-related mental phenomena.
Yeah, thanks. Like in one of our studies, we looked at anxiety symptoms and found that by 3 months, like right by the end of the program, about as many people improved their anxiety as got worse, actually, in the intervention. And then by 6 months follow-up, a lot more people had gotten better than gotten worse. And so it was this idea of like sometimes with mindfulness, like we're actually, it has this approach orientation where we're coming towards our emotions and thoughts rather than away from them. And if there's a lot of challenges in our emotions, especially around like week 5 or 6 of MBSR, where we're really kind of moving towards it, could that like stir things up? And I'm just curious, like your perspectives on that in terms of for someone who's working with anxiety, how they might go through that arc of might it get worse for a little while maybe before it gets better, or what you see in that kind of domain. And
Yes, that you make a really good point, and we definitely did see that and actually I can show you the adverse events if you like next. But anxiety is one of the adverse events. We asked participants to describe any uncomfortable experiences associated with the treatment, whether it was the drug or the mindfulness. And anxiety was the top side effect of MBSR, although it still was much, much less than the drug. And I think that, as you're saying, people are allowing thoughts, emotions, memories, whatever, to arise that may have been previously suppressed or distracted from. And that in itself can be upsetting. But as we know from exposure-based therapies in the treatment of anxiety disorders, it's better uh, to be aware of and to sort of process through those feelings rather than try to avoid them.
mm, yeah, yeah, thanks. Yeah, I'd be curious. Do you want to share a little bit about what you found in terms of adverse events between the MBSR group and the Lexapro group?
Yeah, sure. Here's the way we did it. There's of course different ways to ask about side effects, and in drug studies, there's a very standard approach of letting the participant know, here's all the side effects that could happen, right? That's part of the informed consent process. But if you say, well, did you have headaches? Did you have, and there's like 90 things, then you tend to over sample, like you get to people over endorse. So instead you say, what are the experiences that you had? What are anything that was uncomfortable or unpleasant that you associate with the treatment? And then they can spontaneously say. So for patients who had at least one adverse event, 78% of people in the drug group had at least one adverse event. That's a lot, right? 78%. But that's pretty much what we see in clinic. Almost everybody who tries an antidepressant notices something, whether it's just dry mouth or some nausea or decreased appetite or sedation. Those are typical side effects. For the meditation group, it was 15%. So, really 3 times or 4 times higher in the drug group. And now I'm going to show you a chart of a list of the types of side effects that were present in 5% or more of patients. So this is only shown if it's 5% or more. And you can see the ones on the left for the drug are the same as what we typically see in clinic. A lot of people with nausea, fatigue, some kind of sleep fragmentation or sleep disturbance, sexual dysfunction, some jitteriness, and then there's anxiety there, and 7 people. Whereas in the MBSR arm, much fewer overall, but anxiety is the top one, and 13 people had that. And then all the other side effects were less than 5%. So we couldn't even find any other that were equivalent to the amount seen in the drug other than anxiety. But I just left them in here so that you all could just see fatigue, trouble concentrating, depression, but very small numbers, like 2 or 3 people.
Why do you think the adverse events were so different between the groups? What do you think was driving that?
Well, I think a drug has effects on all different parts of the brain, like dry mouth, like that's, we're trying to impact serotonin levels and we end up impacting, acetylcholine, histamine, other whole neurotransmitter systems. So it's kind of messy. It's not very targeted,
Mm.
and it's, totally different kind of treatment.
Yeah. We had a question come in from a member of the audience that said, since your study showed that mindfulness and Lexapro both helped with anxiety, but mindfulness had fewer side effects, how should someone decide which path might be right for them? And, for people weighing their options, what should they be thinking about?
That's a great question. And I'll tell you a little story. So I had patients, a lot of times I had patients come to the trial and say, I really want the mindfulness. Can I just take the mindfulness? And we're like, sorry, you can't choose. Like, it could be randomization. It's all for science. We have to do it this way, for the best possible, rigorous study. But, you can take the class, after. So I had one guy who said, okay, I'll do the study. And he was randomized to meditation. And then he came after the whole, 12 weeks and said, well, that was nice, but can I have the drug now? And so I prescribed the drug and he took it and he was like, wow, this is great. This drug is great. I was like, okay, there's certain people who the drug just works better. At the same time, there were people who were randomized to the drug group and said, okay, I'm not really happy about this, but I'll take the drug. They were like, I can't really tell if I felt anything, but can I do the meditation now? So we gave them free, access to the MBSR class, and they're like, this is so much better. This is really what I wanted. This is really helping me. So I think big picture, if somebody's trying to choose between those types of approaches, some things to think about are how much motivation is there, because mindfulness takes time, right? Mindfulness practice takes time, and it's looks like most of the research that's being done is on people doing a significant amount of meditation, 20 minutes a day, 40 minutes a day, maybe not every day, but most days. Whereas taking a medication is a relatively simple, less time involved type of approach. And for people who don't mind potential side effects, then that might be a better option. That depends on the person's priorities.
Thanks. Yeah, I appreciate that non-judgmental approach where there's lots of ways to be happier and healthier, and mindfulness training could be one, and Lexapro could be another, as well as other approaches too, and just see what the evidence shows and then allow folks to choose which path seems best for them. And we've had a few folks ask about whether mindfulness training could help when someone is tapering off anxiety medication like Lexapro. And have you studied that, or do you think it could be helpful in that situation? This actually came up quite a bit with people just wondering if mindfulness could help ease the process of coming off medication.
Yes, we don't have that data, but the folks who study depression have data on using mindfulness approaches to decrease the risk for relapse in depression, which it does decrease the risk for relapse. I'm not clear whether perhaps some people mean the discontinuation effects, which are kind of like side effects when you come off of Lexapro or other SSRIs. People experience just the body adjusting to not having the medication, which is like dizziness and flu-like symptoms. So I don't know if it would help with that, but in to the extent that meditation could help buffer the effects of stress and the you know vulnerability to anxiety symptoms, I think it would help, but I would start way before. Like, don't just start the meditation when you come off the drug, but like a month before, so you build up a practice.
Thanks. Yeah, wise advice, I think. Do you want to shift to sharing some slides about the next study?
Yeah,
This may be
yeah.
the
So
killer one.
yeah. So this came from a question about the rest of our research these days is on self-compassion and loving kindness. So I became more interested in that aspect of the Vipassana tradition because our patients with depression and anxiety often have a lot of self-judgment and negative self-talk. And so I became really interested in metta and other practices that could potentially protect people from those negative self-referential processing states. And so we did one cross-sectional study to try to understand the health benefits of metta, and I can tell you about that now. So we were wondering, could metta help with self-judgment and improve overall health? So that's the overall question. And the first way to look at that is to look at people who already do metta. And so that was a study where it's not advancing, let me see. we asked people in the general public to participate in our study if they practiced metta regularly. So this ad was put up at IMS and other meditation centers, and they said, hey, meditate for science. Just come by the lab on your way to the airport in Boston and give us some blood and, fill out some questionnaires and pay them $100. And you can see here the criteria for participation. We didn't want anyone taking certain medications that would affect these biological measures, and we wanted them doing metta for at least 5 years and at least one meditation retreat. And so we had about 22 people come, which was great. And I'm so grateful for those people for coming to our lab and letting us take their blood and do testing on them. And you can look at their demographics here. This is a highly educated group with mostly white. And then we had to specifically ask about things that would affect stress or biological things like cigarette smoking, which affects telomeres, which I'll talk about in a moment, and past depression. And then we had to find controls from the community that matched on all of those attributes because we didn't want to have a confounder. So we had to carefully select people that were the right age, so our ads looked like, are you between 35 and 45 and you've had depression, but you're not a smoker and you have a graduate degree? That's basically the kind of people we needed to make this the most exact match. And then you can see here the meditators had an average of 5,000 hours of lifetime meditation. And here's the range. One person was 20,000 hours. And then specifically loving kindness or metta, the average lifetime hours was 891. So this is a very experienced group. And so we're interested in this biological measures of stress. And it turns out that telomeres measure the impact of stress and longevity. So it's already been established that shorter telomere length is associated with aging. So they've taken, for example, populations like caregivers of children who are disabled or caregivers of Alzheimer's patients have shorter telomeres than they should for their age. But outside of the stress, the telomeres just slowly shorten with time with cell replication. There was another group that found, after participating in a meditation retreat, telomerase, which is the enzyme associated activity, was higher in meditators compared to non-meditating controls. So that made us think that, this might be true for telomere length itself. Here's our overall data. So put everyone together, we showed that people who meditated did have longer telomere length than the controls shown in green, not quite reaching statistical significance. And then we were interested in whether there was a gender effect, because most of our meditation studies have a higher amount of women in them. For some reason, those are the people who agree to be in studies. So it's something like 70% of women are women. And here's an example. Here's broken down the telomere length. So in men, shown on the left, there wasn't really a difference between the metta practitioners and controls, but in women, there was a significant difference between women. I mean, yes, women who did metta versus controls, suggesting that metta might protect people against this impact of stress on aging. So there's something associated with metta or something else, we don't know, but this suggests that it could be that doing regular metta would decrease the risk for accelerated aging from stress. Does that make sense?
Yeah.
Oh, and then these are all the people I want to acknowledge for all the different studies that we've had great collaborators in Boston at MGH and Cambridge Health Alliance, also at NYU. This is from the TAME study, and then all our meditation teachers, which you can see listed here, and funders. So really appreciate all the teamwork and effort that went into these projects.
Thanks. Yeah, interesting with the aging. Longevity medicine is such a hot topic right now, and how can we promote successful aging and longer lives and healthier lives, not only lifespan, but health span. And and seeing the work on telomeres and telomerase has been pretty interesting to me. I think those results are pretty promising. A sample size of 37 is like pretty small from a statistical power perspective. So to see a p-value 0.08 in the whole group isn't so surprising with that. But there's also been systematic reviews and meta-analyses where they combine all the especially intervention studies on telomere outcomes and finding signals there, which I think is promising. I'm curious about the gender difference thing there. I get again, sample size is even smaller when we split it into men and women, so we've got to keep that in mind. I haven't seen a lot in literature looking at gender or sex specific effects of meditation, and I think it's actually a problem. Like, I think we need to figure that out, and also see if there's ways to better match different folks. But I'm curious, have you seen gender differences in other elements of your work, or in the field as a whole?
I just know from my collaborators that more women enroll in the studies, but
Yes.
at least in the TAME study, of course, we had only 25% men. But to the extent that we could statistically examine gender differences, we didn't see a difference in like anxiety and depression outcomes. So it seems like that the effect might be equal on that level.
Yeah. Yeah, it'd be good to see how it all plays out. We did a systematic review and meta-analysis in like college students going through mindfulness training, and in studies that had a higher proportion of males than females, the effects tended to be stronger. But in some preliminary analyses in our studies in older adults going through the mindfulness-based blood pressure reduction program, again, we don't have big sample size for sex-specific differences, but we're seeing a bit of a stronger signal in females than males. Uh, and so I'm sort of like, I kind of seen it go in both directions, and would love to see more kind of combined analyses, really asking that question to see if there is something different going on between the genders, or is it just kind of study to study, random noise kind of thing? And but appreciate you asking that question and showing what the results are too. I think we need that done more. Um, I would be curious. Well, this is so just of course, you're an excellent researcher, but also as a clinician, as a psychiatrist, I'm curious to hear more about like how have the mental health profiles of your patients shifted over the past decade, and what do you see as the key drivers of those changes, and how might mindfulness training help address them, assuming you have seen some shifts in patient profiles over the last decade.
I think the biggest shift came with the pandemic
Yeah.
because people became awfully isolated, and because of various larger societal factors, they haven't gone back to their the amount of contact with other people that they used to. And that's in the context also of decreased community engagement, as described in the book Bowling Alone and other sociological examinations of people's habits. And so I think we have seen, news stories about how anxiety is at its highest level now, and stress and depression. And I think some of that is due to people being in this artificial state where they're isolated and separated from other people. Like it's just not natural for human beings to be in their house alone all day. Like we didn't evolve that way. Our brains don't work that way. And we've lost something from how life was lived 50 or 70 years ago, where
Mm.
there's a lot more engagement with the community and neighbors, and it was expected people drop by or whatever. And so I think that sometimes people feel this discomfort and distress, and it comes out described as anxiety because there really isn't a better word. And anxiety is something that's kind of recognized and accepted. But I suspect that if we were to somehow get people more connected with people, not online, but in person with other groups of humans, other humans, and talking about things that are important to them, that we would see less of this distress and anxiety.
Yeah. Yeah, I like that idea of just almost like befriending our emotions, so if there's anxiety there, to see that as a message or with kindness and seeing what it's sharing and seeing what the fundamental drivers of it are and then what are solutions. And so for some of us that are maybe not as connected as we could be, maybe that's a solution. And I can honestly even feel it in myself. Like before COVID, we had more people over. We had more parties and stuff. And then COVID was like long enough to set like a habit. And so now on the backside, I was actually just been thinking about this. I'm doing a lot more loving kindness meditation myself right now. And I'm like, need to start having people over more again. And so what you're sharing even resonated with my own experience of the pandemic and how the habits can kind of come in. And now what's being called for at this moment in history and how to
Yeah.
skillfully respond.
And I might say that clinically, for patients with anxiety disorders, it's especially social anxiety. I guess that's really what I mean here. It's worse if you avoid sort of putting yourself out there. So for people who are already vulnerable to social anxiety, to have a pandemic come and then they set these habits, as you say, and then it's like, oh, I just don't want to, I don't want to go to that party. I don't want to have that dinner, or I don't want to talk to that neighbor. I'm just going to look away when they pass or whatever. That actually makes social anxiety worse for those people. So our instruction is always like, don't avoid, because that makes your life more and more constricted, and then it's harder to get back out.
I think that's one of the ways group mindfulness and meditation training can be supportive for folks who may have more, say, social anxiety, because we can be in community in silence. And then when we speak, it's really deliberate and talking about important elements. And there's also like safety in terms of whether we're comfortable sharing or not, and whatever it is respected. And so I could almost see it as a healthy way to try to transition more into live community. And in fact, most of the studies that have looked at impacts of mindfulness training on loneliness show uh, improvements in loneliness. And whether it's because people are making more relationships in the group, or whether it's allowing us to be alone, but to have it a more contemplative practice. So just be there in the present moment, just washing the dishes for the sake of washing the dishes and, being there moment by moment. So it's sort of like loneliness can be variable. If I have like 3 or 4 close friends, I don't tend to feel lonely. But my wife, who's much more extroverted than me, if she has 3 or 4 close friends, she may feel a little more lonely compared to if she has like a good set of like 7 or 8. And so loneliness can also be relative. And so how can mindfulness training help us lessen those feelings of loneliness, whether it's through increased connection or the ability to just be with the present moment, whether we're alone or with others. And I know this is a question that came up with the audience. In your study, some people did mindfulness in person and others did over Zoom. And did you find that one way worked better than the other, especially for people dealing with social anxiety or panic? So this is kind of flowing from what we were just talking about, but then you actually had a bit of a moment, it sounds like, in your study to test that a little bit. I know it was driven by the pandemic, but
Yes, yeah, so not randomized, so that means we can't really say for sure, but it looked like when we moved both treatments online, so if you will, here's drug and here's MBSR, which you remember MBSR is still within the margin. When we went online, drug improved and MBSR decreased in power, so we were no longer finding non-inferiority. So for whatever reason, and who knows why, MBSR didn't do as well online, and it was no longer non-inferior to drug. And I might just say that there's a theory that sometimes people say, well, that's because during the pandemic, people were more anxious, so they were harder to treat. So we looked at that. And if you look at baseline anxiety level, it actually was less during the pandemic. That the second population had less anxiety than the pre-pandemic population. So it wasn't that. So we don't really know what it is. But when journalists call me about this study and they ask, well, can't we just do, some of those apps and get the same benefit as the drug? I will say, no, that's not what the data shows. We do not have any support for an app-based approach. This is really with people, human beings, ideally in a group, video conference if necessary, but even better if it's in person. The way the brain functions best in person with other people live.
Yeah. Okay. All right. Well, good to see that it's like an interesting natural experiment where we weren't able to randomize them to online versus in person, but at the same time, a natural experiment happened. And so let's see what those data show. And it's an interesting signal there.
We are doing a study this summer where we're randomizing because nobody has that data. No one in the community has that data. So this summer we're randomizing MSC, the mindful self-compassion, to online or in person, and then we'll have the answer for you.
Good. Yeah, I'm glad you're doing that. We did a systematic review where we looked at studies that were offered online versus in person. And in our first set of analyses, we found the in-person had stronger effects than online. But then when we did further analysis, we found that the studies that were happening in person tended to have a sicker population. And so they tended to have more room to improve. So when we statistically accounted for the level of illness at baseline, we saw an equivalency of effect between in-person and online delivery. But again, this was systematic review, so not randomizing people to online or in person, just looking at studies that were online and looking at studies that were in person. So the fact that you're randomizing people to that, I think, is a much stronger test of that hypothesis. And I'm glad that you're doing it. I'll be curious to see what you find.
But your study can also be helpful for people who are trying to decide, right? Because it sounds like if they have more severe symptoms, they should choose the in-person version, right?
Potentially, yeah. Certainly that would be consistent with what the evidence was showing. It could also just be floor effects, where people who aren't as sick don't have as much to improve on. So we'd see smaller effects just due to that. But that's what your study is going to help us understand, is if we randomize people to one or the other, really to see what's going on there. We had a question come in from Barbara who asked, maintaining a mindfulness practice isn't easy for everyone. And how effective is mindfulness meditation long term with people who have anxiety? Do you know what the evidence suggests around that?
We did follow up people at the 6-month mark and at the 12-month mark, a whole year later. And the effect does decrease over time. But I think it's mostly because people stop practicing. So if you're asking the question, does meditation lead to like a aha moment that changes the way you think about life from there on, versus that it happens because you're doing a regular practice that reinforces certain habits and skills, then it would be the evidence supports the latter, so that you'd have to keep up the skills, I guess is a weak analogy, to have the effect.
Yeah, right. Okay. Yeah. Um, Rebecca asks, for people with anxiety who are on the drug, but it's not working well, and they're looking for other solutions, but they're not really interested in mindfulness, what suggestions do you have that might help motivate them to try mindfulness?
Oh, I was going to answer the question, what other lifestyles treatments have
Yeah.
the evidence base to motivate people to do mindfulness? That's hard because there's so much it takes so much work that it really feels like it would need to come from within.
Mm.
But as people feel better, they usually find engaging in treatment easier. So I'll answer the other question, which is, are there any other lifestyle things they can do? Which is, there's really good data for exercise. It's pretty amazing. People have been looking at aerobic exercise as a treatment for anxiety and depression, and especially in depression, it's almost as good as drug. It's very, very powerful. So that's a great option for people who don't want to take medication
Yeah.
or boost the effect of the medication.
And cognitive behavioral therapy is quite effective too. Is that correct for anxiety?
Yes, especially if the disorder has a avoidance component. So if the person has, for example, panic disorder where they're avoiding driving on highways or riding the subway, or they have social anxiety disorder and they're avoiding, um, you know, being in groups or going out to parties or having friendship groups, if there's an avoidance component, then CBT is a great option, because the most powerful part of CBT is the B, the behavioral exposure part, and you work with your therapist to come up with a series of graduated exposures to slowly train the mind to feel better in those contexts.
Mm. Yeah, thanks. Yeah, I'd be curious, as I see you often enough on NIH grant review panels, for example, and you're one of the leading scientists in the field and have had a history of asking important and innovative questions. And I'd be curious to hear your thoughts about what you think are some of the most important research questions to be asking at this moment in history. Where do you feel like the field would be well served to go?
I don't, I'm not sure that I have many good ideas. Probably you have better ideas being in the middle of the mindfulness center. I'm very clinically focused, so I'm really thinking about patients and how we can help people with specific symptoms of anxiety and depression. So one thing that we've been really turning towards is trying to decrease judgment, self-judgment, because there's such a problem with self-judgment and self a lack of self-compassion. And so that could be a direction that research could take. I think other people are involved in questions of dosage and timing, like how to make it a good balance between what's feasible and what's effective. Um, and then other people are engaged in understanding the biological effects, such as neuroimaging, to sort of confirm the clinical evidence and also provide potentially some information about how the treatments are working.
Mm. Yeah, thanks. Yeah, I think one of the things that you and I have talked about is just around like implementation science perspectives of here's this great clinical trial that you did suggesting MBSR is equivalent to Lexapro, maybe even fewer side effects. And so if you wanted to start offering this to your patients, could you? And would it be covered by health insurance? And if not,
That's the hardest part, is the health insurance.
yeah. Do you have thoughts on steps around that? Like say with acceptance and commitment therapy or dialectical behavioral therapy that can happen one-on-one with a clinician, that can be covered by health insurance now. What about MBSR? Like what's your thoughts on directions
So
for it?
if it's a clinician, a licensed clinician, they can always bill using group therapy code.
Mhm.
But if it's a meditation teacher, there's no obvious way to do that. So what we really need is CMS, like Center for Medicaid and Medicare Services, to devise a code that would allow the educator, which would be the meditation teacher, to bill for the treatment. And that just needs to, I'm hoping my study can provide some support for, using MBSR if it's equivalent to drug. But we just need to get them to assign a code, and then the private insurance companies will follow.
Mhm. Yeah. Okay. I know we're coming up close to time here. We like to end this series with a similar question for each of the speakers too. So why don't I just offer that? now. And so looking ahead to the future, where do you see the study and practice of mindfulness best serving humanity?
It seems like we are at a moment in our nation's history with a particular challenge around compassion and understanding each other. And I wish that we could use mindfulness to breach the divide between our own in our own population. I don't know how to do that, but it seems like because we've been in research studies been able to show that meditation training increases common humanity, which is a subscale on the self-compassion scale, that we could have people be coming together in other contemplative practices too, perhaps mindfulness, but also there's others in different religious traditions. But it seems like that could potentially help people come together.
Mm. Yeah. Yeah, like the mindfulness practices, like say, that just have elements of curiosity, and non-judgmentalness and compassion. Um, and so how can we simply be curious about each other and come to see as close to the truth as possible about how to be healthy and happy and to create societies that are highly functioning and supportive.
Yeah.
Yeah. Well, thank you, Dr. Hoge, for visiting us today and sharing your research findings and your wisdom. I always appreciate our conversations and really wishing you the best on your next steps too. And then, Fran, should anything else that you want to connect about before we close up for the day?
Yeah, I just want to echo your thanks and to both you, Eric and Liz, for being here today and for this insightful conversation. I just posted a poll. I know we're kind of coming up on the hour here, 4 brief questions, if you have a moment to fill that out. And then, as I mentioned earlier in the talk, we will be sending up a follow-up email probably early next week with the link to the recordings, as well as some information about our programs. And we'll be pausing the series for the summer, but picking up back in September. So thank you so much. We had an overwhelming number of questions come in and so thoughtful, and we will be reading through those, and I'm happy to share those with you, Dr. Hoge and Eric as well. It just really is very insightful and helpful to see where everyone's thoughts are and what kind of questions are coming up. So
I'm
with
so, I
that,
just want to say I'm so happy to have been here today. Thank you so much for inviting me. It was a real pleasure speaking with you.
yeah, thank you.
You. Okay. Well, bye, everyone. Thanks for joining us, and look forward to seeing you in the fall when the series continues.